can start.
Okay, then hello everybody. It's my great pleasure to welcome you to our today's webinar. My name is Jens König. I'm a pediatric nephrologist in Münster, Germany, and I have the great honor to welcome and introduce to you today our today's speaker, Professor Manuel Ferraro, who's an absolutely expert in the field of almost every kidney disease. But Professor Ferraro is an associated professor of nephrology and the director of the unit of conservative management of chronic kidney disease at the Università Cattolica in Rome. He holds a Master of Science degree in epidemiology at the Harvard T.H. Chan School of Public Health and also a PhD in endocrinology. His main fields of interest are the epidemiology and metabolic aspects of nephrolithiasis, nutrition, electrolyte disorders, chronic kidney disease, and genetic kidney disease. He's a board member of many clinical registries, among them the ERKNet Registry, the ALIS and ERA Registry, and the Italian Dialysis and Transplant Registry. Professor Ferraro will give us a lecture on the topic of cystinuria from the adult view, and at the end of the lecture, he will also be available to answer any of your questions. He just said we have about 6 hours time. So please do not hesitate to write down your questions into the chat, and I will read them out at the end of the lecture. So Professor Ferraro, thanks for being with us today and for sharing your time and knowledge.
Thank you, Jens, and thank you for the kind invitation to deliver this talk on cystinuria. These are my disclosures, none of them relevant to the talk, and this is the overview of today's talk. We will start with the pathophysiology and genetics of cystinuria, epidemiologic data, the clinical picture, the diagnostic features, and finally treatment and follow-up. But before starting, let's get to know each other a little bit better with some general questions. The first one is, what is your main specialty? You have, I think, 1 minute to respond, although I think you would need less than that.
So your result would be you have to deal with mainly pediatric nephrologists, 54%. Then we have 38% of adult nephrologists and 8% are other, who are not pediatric urologists, and no adult urologists today.
Okay, so there is a nice mix of pediatric and adult nephrologists today. So hopefully this will be helpful. Second question, how many patients with cystinuria have you treated in the last year? Less than 5, between 5 and 10, between 10 and 20, or more than 20?
All right. Actually, there's a lot you can teach us today. It's 84% who have treated less than 5 patients, another 12% with 5 to 10 patients, and only about 4% with between 10 and 20 patients. No one with more than 20.
Okay, that's also interesting. And finally, what definition, according to you, best describes cystinuria? An X-linked condition characterized by accumulation of cystin in the cells, an autosomal recessive condition, an autosomal dominant condition characterized by abnormal urinary excretion of cystin, or autosomal recessive.
All right, here the majority answer chose for answer D, autosomal recessive condition characterized by abnormal urinary excretion of cystine is 68%. 17% decided for autosomal dominant condition characterized by an abnormal urinary excretion, and there's 9% going for an accumulation of cystine in the cells in a recessive condition, and 6% for an X-linked condition.
Okay, so most of them got the right answer, as we will see. So now that we got to know the audience better, let's start with reviewing the pathophysiology of this disease. As the name implies, the culprit of cystinuria is cystine. Cystine is a homodimer composed of two molecules of cysteine bound together by a disulfide bridge. Normally, cysteine, together with the other D-basic amino acids, is almost completely reabsorbed at the proximal tubule. However, during the cystinuria is characterized by a defect leading to increased excretion of cysteine, which in turn, as we will see, give rise to the clinical picture in which recurrent nephrolithiasis and renal colic dominate, and there is a high risk of developing both acute and chronic kidney disease, including kidney failure. Focusing a little bit more on the proximal tubule, and especially on the S3 segment of the proximal tubule, this is where this reabsorption happens. As you can see on the right, this transporter has the role of reabsorbing D-basic amino acids, so cysteine, ornithine, lysine, and arginine, in exchange with neutral amino acids. And it is composed of two structures. So it is a heterodimer with the transporter proper, which is called B0 plus AT, encoded by the solute carrier family 7 member 9 on chromosome 9q. And the other molecule is ERBAT, which is encoded by SLC3A1 in chromosome 2p. A defect of this transporter gives rise to an extremely high elimination of cysteine, moving from a normal range, which is lower than 0.13 millimoles or 30 milligrams per day, up to 15 millimoles, which is 3,600 milligrams per day in patients with cystinuria. In turn, this gives rise to a picture of nephrolithiasis and crystal formation. The reason for this, we can speculate on the on this plot that we could that I found in this clinical practice recommendation on cystinuria by the ERKNet and Eurogen groups led by Professor Aude Servet, which tells us that the solubility of cysteine, which is the amount of cysteine allowed to be in soluble state in urine, is a function of urinary pH, and it increases at higher values of pH. So a normal individual will have such a low amount of cysteine excretion that there will never be solid phase passage of cysteine, whatever the urine pH. On the other hand, an average cysteinuric patient will have excretions of urine cysteine in the range of about 3 millimoles over 24 hours. That, for instance, in a urine volume of 1.5 liters, means that the concentration of cysteine in urine will be about 2 millimoles per liter, which is consistently higher, much higher than the solubility point across most of the range of physiologic urinary pH, until we get to very alkaline values, about 7.5 or more. And these higher concentrations provide the chemical drive for the formation of crystals. We also have to account for the individual variability, because this is a theoretical curve, which is, by the way, quite often used in clinical practice, but individual patients will have solubility values of cysteine that will be very scattered across values of urine pH. This is likely due to the influence of other compounds, other mineral electrolytes and macromolecules relevant to lithogenesis that might differ in concentration from individual to individual, and to the concept of heterogeneous nucleation, which is the growth of cysteine crystals of a different chemical nature, for instance, calcium oxalate or uric acid. And it has been shown by Charles Pack in 1983 that there is no strict identity, one-to-one identity between the theoretical supersaturation for cysteine and the actual measured saturation for cysteine in individual patients. Which means that if we really wanted to be sure about the chemical drive of patients with cystinuria, we could directly measure the cysteine supersaturation ratio. So starting from a sample of the patient's urine, which should be yellow, however, not pink. By the way, we can include a solid phase, definite amount of cysteine in this urine. And then after some time, what will happen is that either if the urine are undersaturated for cysteine, the solute will dissolve in the urine, or if the solution is already supersaturated for cysteine, crystals will accrue over the solid phase. In any case, we can measure the amount of cysteine, the concentration of cysteine in the original sample and after steady state, and the ratio will provide information on saturation state. So the supersaturation ratio, if below 1, means that the urine are undersaturated for cysteine. If it is above 1, means that the urine are supersaturated and then will tend to form crystals. With regard to genetics, we know that this condition is classified as autosomal recessive. The current classification is has supplanted the traditional classification that was based on the amount of cysteine excreted by relatives of the proband, and it is now based on the molecular lesion. So we have a type A disease when there is a biallelic mutation of the SLC3A1, type B when there is a biallelic mutation of SLC7A9. Occasionally, there may be a co-occurrence of mutations in both genes. However, the condition of compound heterozygous AB is usually not associated with disease. So we still need to have a biallelic mutation, either A or B, in order to have the clinical phenotype. Individuals heterozygous for SLC3A1 generally have normal urinary excretion of cysteine, unless there are some specific mutations such as duplication of the exons 5 to 9. On the other hand, heterozygous for SLC7A9 tend to have elevated urinary cysteine excretion, and sometimes they form cysteine stones, which is the reason why SLC7A9 can be considered as autosomal dominant in terms of pattern of inheritance with incomplete penetrance. To date, we don't have a clear genotype-phenotype correlation, and this, together with other diagnostic features that we will see in a moment, is the reason why genetic analysis is not central in this disease compared with other rare conditions. This is a very elegant study performed by Professor Dell'Ostrologo, looking at the excretion of the basic amino acids in urine in heterozygotes. These are relatives of cysteinuric probands, showing that type A heterozygous have urinary excretions that basically overlap with controls, whereas type B heterozygous have a very scattered and heterogeneous excretion of cysteine, which for some individuals is also compatible with the excretions that we find in homozygous individuals. In terms of epidemiology, the worldwide prevalence of this disease is about 1 in 7,000 individuals, which makes it the most common cause of monogenic kidney stones. There is also quite a large ethnogeographic variation, with estimates ranging from 1 to 2,000 in the Eastern Mediterranean area to much lower prevalences of about 1 to 100,000 in Sweden. With regard to prevalence in the kidney stone forming population, it is generally thought that 1% of adult stone formers are affected by cystinuria, and 5 to 10% of children. More ratio of about 10. And the is at 22 years. A quarter of patients with a clinical. The cystinuria being relatively adult has been challenged by a series of studies that has by the Hildebrand. These studies cohorts mix pediatric and adult with a genetic approach of including a panel of 30 genes, most monogenes. One of them sequencing of secondary.
Manuel,
yes.
Sorry for interrupting you. We have some technical problems with the audio.
Okay.
We can hear you in a very interrupted way. Maybe you could try it a bit closer to the mic.
Can you hear me?
Oh, that's a lot better. Yes.
Me?
We can hear you right now. Yes. Can you hear?
Better?
It sounds better. Yes.
Okay, it's closer now, the mic.
Fantastic. Thanks a lot.
Okay. Yep. No problem. So if we isolate the results for cystinuria, we can see that overall the prevalence of cystinuria was 5.4%. However, the proportion was not particularly among those younger than 18. Should that these cohorts necessarily represent general forming population, because quite enriched with cases with nephrocalcinosis and with positive factory. So the clinical picture very dominated by features, with this feature, which is kidney stone, though that is quite common.
Excuse me, can I interrupt you? I think it's rather a connection problem than a microphone problem. So I assume the connection is not so stable, but you are very the voice is very interrupted in between.
Okay, actually, is there anything that you suggest that I can do?
Is there? Is the connection of the Wi-Fi or the fine?
No, it's wired.
Ah, it's wired. Yeah, then it should be okay. I don't actually know then. But maybe keep talking that I see if it changed anything.
Can you hear me?
Now we can hear you. Yes.
Okay. Okay, let's see.
Let's see. Fluent always, but hopefully it works.
Okay, let's. I'm not sure what else I could do, so I will go on.
Okay.
Good.
Okay. I was saying that the other feature that more recent studies are pointing to is the high prevalence of chronic kidney disease in this population. In terms of composition, only about half of cystinuric patients will have pure cystine stones. And this is the the classification of cystine stones according to the morpho-constitutional approach by Professor Dodon in France, which describes two subtypes of cystine stones named 5A and 5B. Both of them have a yellowish color. The difference is that for type 5A, the surface is relatively rough and the inside of the stone is poorly organized, whereas type 5B has a smooth surface and it shows layers of material at the periphery with an unorganized core. And according to these authors, this latter type of stone is typical of cystinuric patients with inadequate medical management or with urinary stasis. The other half of cystinuric patients will form either mixed stones with a certain amount of cystine coupled with other salts, or in 10% of cases, stones with no cystine at all, so other types of cystine altogether. This is a case that I would like to show that we saw in our clinic a couple of months ago. A 42-year-old woman with a history of recurrent kidney stones since 18 years old, several urological interventions, more or less one per year, and a positive family history for stones with her paternal grandmother affected with stones. She had undergone in February 2019 a composition analysis with the wet chemistry approach, which is not very accurate, but anyway, and it is semi-quantitative. It reported calcium 1+, oxalate 2+, and phosphate 1+. In September 2022, during one of her other approaches with urologists, she had the possibility to have another composition analysis, again wet chemistry. In this case, the analysis reported 100% cystine. So this is the point where the patient was referred to us. And since up to now, the patient had only undergone wet chemistry analysis that, again, are not particularly accurate. And since she had another stone available that she had passed meanwhile, we decided to perform infrared spectroscopy on the stone, which confirmed the presence of 100% cystine. At that point, a 24-hour urine collection confirmed the diagnosis with a very high excretion of cystine of 1.6 millimoles. This is, in my mind, should make us aware of the importance of performing a compositional analysis of stone whenever we have the possibility. In fact, if the patient had stopped investigations at the first stone analysis, she would have probably been classified as an idiopathic calcium oxalate stone former. Maybe someone might have hinted to some incomplete DRTA or primary hyperparathyroidism or medullary sponge kidney because of the amount of phosphate in the stone. But positive family history would not have helped because also idiopathic calcium stones tend to run commonly in families. And the reason why cystinuric patients form stones of other chemical nature, is linked to the concept that I mentioned earlier of heterogeneous nucleation and of the role of other lithogenic salts in urine. This is another work by the group of Professor Pak showing that the proportion of cystinuric patients with other abnormalities is relatively high. 44% of them have hypocytraturia, 22% high urinary uric acid, 20% high calcium, which makes these patients at risk of forming calcium oxalate stones, calcium phosphate stones, uric acid stones. And this might form the basis for heterogeneous nucleation. Another feature of kidney stones is the high recurrence rates, which is much higher than the idiopathic stone disease. 45% at 3 months without treatment, going down to 25% at 3 months with optimal treatment. However, these are very large recurrence figures. And virtually at 5 years, almost all cystinuric patients have at least one recurrence event. So this is a very active and very severe disease. The radiographic appearance of the stone, the plain X-ray, they are not visible unless they are quite large because they are faintly radio-opaque. In CT scan, of course, they can be seen, and it is interesting to note that their density at CT scan is intermediate, is lower compared with calcium oxalate stones, about 600 ounce-field unit, compared with about 1,200 on average for calcium oxalate. And in fact, this study showed that the ounce-field unit in the core for calcium oxalate is significantly higher, but on the other hand, it is very difficult to discriminate between cystine stones and the more common uric acid stones based only on ounce-field units. So certainly the imaging approach is not useful in terms of diagnosis. There are also some interesting studies that looked at the papillary appearance of patients with cystinuria. These are endoscopic images obtained during endourological procedures, showing that the ducts of Bellini of patients with cystinuria are particularly enlarged, and at higher magnifications, we can see plugs of crystalline material that protrude from the ducts themselves. On the right, we see another feature that is the presence of large masses of crystalline material that lie under the urothelium. In this case, the urothelium, as you can see, has been unroofed, so this mass of cystine has been exposed. Even more interesting is the histological finding, showing a very significant degree of involvement of the renal parenchyma, in particular with the presence of frequent intraluminal plugging in the inner medullary collecting ducts, as you can see in the with respect to the double arrows, and also occasionally for the thin limbs of the loops of Henle. So this is unsurprising when we notice this histology, that patients with cystinuria also tend to have a certain degree of reduced kidney function. And this has been assessed in a large group of patients from the French cystinuria group that showed, first of all, that the majority of patients, again, have some degree of kidney dysfunction with a GFR below 90 milliliters per minute, and that about 30% of them have an overt chronic kidney disease with values of GFR below 60 milliliters per minute. In this particular series, about 1.1% of patients required renal replacement therapy. And among the major risk factors for having chronic kidney disease, the authors found high blood pressure with an odds ratio of 3.3 and the extent of renal parenchyma damage with an odds ratio of 4.4. So the diagnosis, to establish a diagnosis, we need at least one of these elements that you can find here: an abnormally high 24-hour urinary cystine excretion, the presence of cystine at stone analysis, which should be performed with infrared spectroscopy or X-ray diffraction rather than with wet chemistry techniques, the presence of cystine crystals, which we'll see is highly specific, although not sensitive, and in certain cases, especially in relatives of siblings of a proband with genetic analysis. And we usually start from an individual with a history of kidney stones. This is a flowchart showing that the start for the investigation of cystinuria is the presence of stone at any age or a family history. Now, I must notice that in the adult setting, this is not completely true. In fact, we don't necessarily perform a full metabolic investigation in all stone formers, because kidney stone disease is quite frequent, very frequent in the general population, about 9% of the general population. But in those at high risk, such as those with highly recurrent disease, with significant family history, with early start of clinical phenotype, a full metabolic investigation is warranted. We can perform a diagnosis either by stone analysis showing cystine, and this is enough to make a diagnosis. However, stone material is not always available because, for instance, the patient might have passed a stone and without retrieving it, or the urologist might have performed the procedure without collecting stone material. We can perform a urine microscopy, and if we find the typical hexagonal crystals, this is again enough to diagnose cystinuria, because as I showed, for a chemical drive to be present, the patient has to be affected with cystinuria. If this is not enough, we can the patient can undergo a urinary cystine screen, traditionally in the form of a qualitative Brand test or nitroprusside test. However, this has been abandoned because for a number of reasons, especially because we still need a quantitative determination of urine cystine, both to confirm the diagnosis and to correctly manage the patient, as I show you. So I would recommend skipping this option and going to the quantitative urine cystine analysis directly. These are the cystine crystals that can be seen in morning spot urines, or according to some other authors in random spot urines. The yield of this diagnostic technique is variable. Some series showed that 25% of patients, cystinuric patients, show these crystals. Other series report 60%. In any case, we can look at this test as being highly specific. So if we find them, the diagnosis is made, but low sensitive. So we cannot rule out the presence of cystinuria because the patient doesn't have these crystals. These are also interesting because crystal volume can predict stone recurrence in patients with an already established diagnosis. And this has been shown again by Professor Dodon and his group, especially a value of crystal volume in excess of 3,000 micron is apparently very good at discriminating between those who will recur and those who will not recur. Moving to treatment, and looking briefly at the urological approach, the goal, of course, is to reach the completely stone-free status, which is very difficult to achieve, especially because cystine stones tend to be very resistant to application of shock waves. And because of that, and also because of the high recurrence rates in patients with cystinuria, minimally invasive procedures tend to be preferred over surgery. And in particular, flexible ureteroscopy should be used for urethral stones and for renal stones smaller than 20 millimeters. Whether for renal stones greater than 20 millimeters, percutaneous nephrolithotomy can be performed. However, ureteroscopy should be an option as well, in order to limit as much as possible insult to the renal parenchyma. Finally, if the patient is deemed if there is indication to place a stent in these patients, the dwell time should be minimized, and ideally the stent should be removed or replaced within 2 weeks, because the risk of incrustation of the stent is particularly high. Moving to metabolic and medical management, this is really grounded in chemistry. So this is why I summoned again this plot of the theoretical saturation curve. The objectives in the metabolic managements are 3. namely to reduce cystine excretion, to reduce cystine concentration, and to increase cystine solubility. So the first step is theoretically achieved, although it is very difficult to obtain, by reducing salt intake, because there is a direct relationship between excretion of sodium and excretion of cystine, and by reducing animal protein as a source of cystine precursor and of cystine itself. Cystine concentration might be reduced by increasing the solvent, so increasing fluid intake in order to increase urine output. And to increase cystine solubility, we can increase urine pH, and we should be aware that reducing animal protein intake by reducing the amount of potential acids also counts toward increased urinary pH, but we usually need alkali to achieve this. And finally, the use of cystine binding drugs. So although this is the conceptual framework for treatment, in reality and in practice, we follow a two-stage approach, with the first stage made up of conservative measurements. This includes increased water intake, which should point to a urine output of at least 3 liters per day, or even better, a urine output conducive of a cystine concentration that is below the solubility limit. But generally in practice, we aim at 3 liters per day. Urinary alkalinization is obtained with an amount of alkali that is much greater than the amount that is generally used in other forms of kidney stones, namely 60 to 80 milliequivalents per day in 3 or 4 single doses. That should be, and 1 large dose should be prescribed before bed. We aim at a range of urinary pH between 7.5 and 8, because there is optimal solubility of cystine at those values. We don't want to go above that threshold, because at that point the risk of forming calcium phosphate stones becomes significant. And finally, diet, with the reduction in intake of salt below 6 grams per day, and reduction of animal protein. As you can see on the right, there is a large overlap between animal protein and methionine and cystine-rich food. So let's take these concepts and let's see a vignette of a naive patient who has just been diagnosed. So he or she will have urinary cystine excretion of 3 millimoles per day, urine volume of 1.2 liters, a urine pH of 5.5, which are values that are very common in the general population. So according to the urinary excretion and urinary volume, the urinary concentration of cystine of this patient will be 2.5 millimoles per liter, as plotted here on the left. The theoretical solubility of cystine at this pH will be around 1 millimole per liter. So the ratio of these two values will give a relative supersaturation ratio for cystine of 2.4, which is much higher than 1, meaning that there is an active chemical drive for crystal formation. So let's say that this patient is diagnosed and then undergoes the optimal conservative management, increased hydration to 3.5 liters per day, low salt, low animal protein, optimal alkali intake. At this point, the treated patient will have modestly reduced urinary cystine excretion. Keep in mind that this is the most common parameter to tackle. So urinary cystine excretion will generally be almost constant in patients. But urinary volume has grown to 3.1 liters, and urinary pH is now in the optimal value of 7.5. At this point, the concentration of cystine will be 0.9 millimoles per liter. You can see here. The solubility at this urine pH is about 2. So the ratio will be 0.5, below 1, meaning that this patient, if this patient was in this stage for 24 hours per day, for 7 days per week, and for months, any stone that the patient might still have would dissolve over time. However, in reality, it is, first of all, it is difficult to reach this stage of optimal response. It is even more difficult for the patient to maintain this stage. And finally, we should take into account that we are still working with a theoretical curve, which means that the patient might be anywhere in this range. As a result of this, the reality is that in practice, we still rely on the clinical response of the patient. By clinical response, I mean the growth of appearance of new stones at imaging in order to assess whether the conservative management are useful or not. If not, so if the patient fails and has a recurrence, first thing we should do, we should check whether the patient is optimally compliant with the conservative management. If so, and if the patient still has recurrences, at this point we can move to the second tier, which is represented by cysteine-binding drugs. These are two drugs, thiopronin and dipenicillamine, since captopril is no longer used. These drugs have the ability to break the disulfide bridge of cysteine and create some heterodimers with cysteine that are about 15-fold more soluble compared with the homodimer of cysteine. We should take into account that both of these drugs have significant adverse events, including abnormalities in the white blood cell lines, in thrombocytopenia, gastrointestinal and liver disorders, significant proteinuria, including cases of membranous nephropathy, minimal change disease for thiopronin, even rapidly progressive glomerulonephritis for dipenicillamine. So if we decide that the patient needs this second tier treatment, we need to be careful in the follow-up of this patient. Not only these adverse events are severe, potentially severe, they are also particularly common. In fact, this is a study by the French study group showing that 25% of patients under thiopronin have at least one adverse event, and 30% under dipenicillamine, with the 70% and 85% discontinuation rate. So since the safety profile for thiopronin is relatively more lenient compared with dipenicillamine, it is usually recommended to start with that drug and then move to dipenicillamine if needed. Another downside of using cysteine-binding drugs is that once we start using them, we can no longer rely on assessment of 24-hour urine cysteine. This is because total cysteine that is measured in urine includes the fraction that is bound to drug. So at this point, we have no information on the actual activity of free cysteine in the urine. So there is this possibility, which is, however, offered only by a few specialized laboratories, which is based on adding an amount of solid cysteine to a sample of the patient's urine, incubating for 48 hours, and then solid cysteine is removed and weighed, similar to what I showed for supersaturation ratio. And if the weight of the solid phase is reduced, it means that the urine are undersaturated for cysteine. If the weights increase, it means that the urines are saturated despite treatment with cysteine-binding drugs. Finally, follow-up, which is certainly instrumental in a chronic and highly recurrent condition such as cystinuria. In terms of imaging, several centers have different protocols in place. Some of them use CT scans as a first level. Others, in order to reduce radiation exposure, use a combination of ultrasound and CT scan. Some others use ultrasound as first line, followed by CT needed. The frequency of the assessment should be determined usually ranges between 3 to between visits. Cystinuria should be performed during follow-up visits because of the possibility to predict recurrence. However, since it requires standardized protocols, it requires a trained personnel, it requires a timely evaluation with regard to the collection of the urines. Not all centers can perform it, but certainly urinary cystine excretion and concentration should be assessed on 24-hour urine collections, which are also useful in order to assess sodium and thus salt intake, sulfate, and thus animal protein intake, other relevant parameters such as calcium, oxalate, uric acid, citrate. In those patients who have recurrence despite being apparently undersaturated over 24-hour urines, we might perform a split of daytime and nighttime collection, which might sometimes uncover periods of supersaturations. And finally, we can consider, if available, cystine capacity assay in patients on cystine binding drugs. In those patients, we should also perform the complete blood cell count and urinary protein excretion because of the safety profile of these drugs. Finally, since we are dealing with an adult population, patient could and should be empowered with self-monitoring. So it's important that patient monitor their urine pH around the clock. So it means different times over day, and they frequently assess their urine volume at home. So with this, I finished. I thank you. I don't know if you heard anything, if you followed, if you're still there.
Yeah, thanks a lot, Professor Ferraro. It was actually a fantastic presentation, and we heard all of the rest. So audio was fine right now, which is good. However, I don't see any questions yet in the chat, and maybe ask Stephanie whether she can see any questions so far.
Yes, you have to look in the dashboard under questions and not in the chat. There are two. Can you find it? Otherwise, I read one of them.
I have the questions open right now, but I don't see.
There's a question from Matthias Kopak. In infants and small children, we often see crystals of calcium oxalate in urine sediment with no clinical problems and normal ultrasound. How much workup and follow-up is suggested?
So if I understand correctly, the question is the presence of the workup that should be performed in children with calcium oxalate crystals?
Yes.
Independent of the diagnosis of cystinuria, I guess.
No clinical problems in normal ultrasound, yeah.
Okay. So as an adult nephrologist, I would still think that calcium oxalate crystals should ring a bell to the physician. Maybe Jens, you can, as a pediatric nephrologist, you can provide more insight. I would still perform investigation of urine chemistries. It's difficult, certainly difficult to perform. You can do it on spot urines, indexing for urine creatinine, but I think it would be worthwhile for cases of primary to look at if we are talking about children. If you're talking about adults, if there is no history of kidney stones, I wouldn't do anything rather than following up over time.
That's how we would do it, actually, indeed, yeah, as well. Actually, here's an, I can't really see those questions really well. So maybe Stephanie, if there's a second one. Oh yeah, here I find one. Do you advise fluid intake during the night?
Yeah, so the question is whether or not to prescribe fluid intake. It depends on the, so I think that the first element is the actual excretion of cystine of the individual patient. Because there are some patients with, so the excretion is quite variable. And there are some patients that with about 3 liters of urine per day, provided that their urine pH is optimal, are fine. Some others, they tend to have a higher 24-hour urine excretion. Among those patients, you can even prescribe a nighttime, so to wake up in the night, to pee, of course, and to have another drink of water. This is what we do in about 30% of our patients, but this is also a little bit taxing. These are patients that in general have a very low quality of life. So if you also add sleep disturbances, it can be a problem. I wouldn't do it for all patients. I would do it for the theoretical saturation is still need volume expansion.
Okay. So if I may ask a question as well, you have shown that around about 30% of the patients present a reduced kidney function already, but you've said as well, if you stick perfectly to the therapy, stones theoretically could even resolve again. So once the patients stick to treatment, do they have the potential to restore their kidney function?
Well, I'm not aware of actual data showing a potential reversal of kidney disease. So since we are talking about chronic kidney disease, I would say that complete reversal, I would not expect complete reversal. I also would like to point out that even in the optimal management, the practical optimal management of patients might undergo phases of very alkaline urine pH. And in fact, some studies have shown that those plugs that form within the inner medullary collecting duct and the loops of Henle, they're not necessarily cystine. They can also be calcium phosphate. So which means that even if the patient seems to be perfectly managed, I think the risk in terms of intratubular deposition still remain high.
Okay. There is another question from Reza Falevi, who mentions that for children, animal protein is actually important for growth. And she's asking, is there any specific animal protein that contains more cysteine than others to avoid in that case? I think you've shown one slide with some products on there. Yes, we can see it again. Yeah.
Okay. So yeah, in general, it's true that recommendations should be different for adults and for children, because for children, as correctly mentioned, we shouldn't restrict the amount of protein too much. And it also should be noted that this is not really key in managing this disease, because this is it has more to do with avoiding urinary acidification by animal protein rather than changing the urinary excretion of cysteine, which will remain more or less constant. Anyway, what's shown here is that dried cod seem to be, and horse meat, I don't know, these are not very common foods, at least in Italy, but you can, yeah, for children, it's certainly different. I would not stress too much this aspect of management.
Mm-hmm. Thank you for this. And maybe as I don't see another question yet, you can still write them in the chat, whatever you want. I may ask, I find it very fascinating that the crystal volume appears to be connected or associated with the recurrence rate. And I was wondering whether crystals differ in size depending on the hydration state.
Yes, totally. So this is one of the drivers okay. of the crystal of the crystal volume. So that, coupled with the concentration of cysteine and pH, it's kind of a proxy of all these conditions together, and it's easy to implement. I mean, in centers that have the possibility to perform crystalluria determination, because as shown, there seems to be quite a clear discrimination at 3000 microns.
Okay, and maybe a last question from my side as a pediatric nephrologist, and we have a lot of pediatricians here in the audience. 3 liters per day in water intake is quite hard to reach with children, but probably the excretion of the cystine is lower in children as well than compared to adults. Do you have a threshold in mind? Would you advise for parents, is 1.5 liters enough? Does it have to be 2 liters in, for example, school children?
So the general approach, I think, should be similar to what we do in adults. So there is no clear-cut threshold, not in children, not even in adults, because 3 liters for someone with a say 8 millimoles per day excretion of cystine, I'm talking about adults, would still be not enough, even at 7.5 urine pH. So I think the best way to approach, even in children, would be to, ideally, you would measure saturation of cystine in urine. If you cannot do that, you can rely on the theoretical curve and see how much fluid, how much water would you need in order to make the urine undersaturated. Because if this is unfeasible, I mean, at least for adults, it doesn't make sense to only focus on that. It means someone also advocates the use of cystine binding drugs, even as a first step, when once you have such high excretions that you already know that you will not undersaturate the urine with conservative management. So I think there is no clear threshold. You still have to look at the amount of cystine in urine and start from there.
Okay. Yeah, thanks a lot. From my side again, I don't find any further questions in the chat. Steph, do you still see any more?
No, I don't see any other question. I think the people are very happy with the webinar, and they learned enough. They don't have any more questions.
I'm very sure about this. Maybe you can go to the last slide again, that we can announce the next. I forgot to announce the next webinars, which will be, yeah, here they are. Thanks a lot. On the 21st of February, presented by Valentina Capone from Milan and Stefan Kohl from Cologne, about the dysplasia and lower urinary tract obstruction guideline. And in March, on the 7th of March, we got Aude Servet, who was mentioned quite a lot of times today already, with adenine phosphorybazole transferase deficiency, sorry about that, an undiagnosed cause of renal failure, and that will be about stones as well then. So we hope to be able to welcome you again. And once again, thanks a lot to Manuel Ferraro for this fantastic presentation. And yeah, I wish you all a nice day still today. Thanks a lot for joining.
Thank you. Bye.
Thank you. Bye.
Bye.